This is Dr. Robert Watkins, orthopedic spine surgeon to professional athletes and creator of the Back Doctor app. Today's podcast is on lumbar microscopic laminotomy. So what we'll talk about is what is it? Why is it done? How does it work? Why does it not work? What does the recovery look like? And ultimately, you can help figure out, does it make sense for you and for your life? And does it have a good chance to help you out? So laminotomy means make a hole in the lamina. The lamina is the roof of the spine where the nerves, the spinal canal is running underneath it. And so if you get stenosis, where usually the ligamentum flavum is buckling in or the facet joint are overgrown and maybe there's a cyst and a bone spur putting pressure on a nerve, a laminotomy means make a hole in the lamina in order to remove the stenosis and to take the pressure off the nerve. This is different than a laminectomy. A laminectomy has been around for 50, 100 years. That's the most common surgery done in spine forever. Laminectomy means take the whole lamina out. So ectomy means take the whole thing out. Otomy means just make a hole in it. So a laminectomy, take the whole lamina out. Laminotomy, just make a hole in the lamina. And you don't have to take the whole thing out. And that's typically what we do these days by making a hole in the lamina. It's kind of a keyhole surgery or a roto-rooter, some people call it. But basically just by making a hole in the lamina allows you to get access to the spinal canal, to take the ligamentum flavum out, which is buckled in, putting pressure on the nerve, also to shave down the facet joint, any bone spurs or cysts or overgrowth from the facet joint, putting pressure on the nerve. And then at the same time, you can go around the nerve and check the disc and see if the disc is bulging back or if there's a herniated component putting pressure on the nerve. So if you do a microscopic laminotomy, and microscopic just means use a microscope, which makes the incision smaller, makes the visualization better, allows us to be less invasive, but still get to the pathology safely and treat the problem. So the difference between a laminectomy and a laminotomy is just less invasive. And the key functional component is that if you do a laminectomy, you decrease the rotational stability between the two facet joints. And whereas if you do a laminotomy, you're just making a hole in the bone, but you're preserving the arch. So the arch that is connecting the two facet joints is still functionally intact, and you're essentially preserving the stability of that structure. So the stability of the spine comes from the disc in the front and the two facet joints in the back. And that provides 95% of the stability to the segment. So as long as you preserve the disc and preserve the facet joints, you can work in this keyhole surgery, do the laminotomy, shave down any overgrowth, and still preserve the stability of the segment. And that's why we prefer the laminotomy to the laminectomy, which decreases some rotational stability, even though the results have never really been shown to be that much different. But in our experience, people leave the hospital either the same day, sometimes they stay overnight, and overall their pain is less and their overall recovery is better by preserving the arch of lamina, but making a hole in the lamina does not decrease stability, and therefore we do that because it still allows us to most safely take the pressure off the nerve and to preserve the results. Nobody wants to have a super minimally invasive surgery that doesn't last. Well, by doing a laminotomy, it creates some room for the nerve, gives the nerve room to drift back into this empty space, so hopefully it'll last for a long time. The most common condition treated with a microscopic laminotomy is spinal stenosis. And stenosis means restriction or narrowing of the spinal canal. Stenosis forms from basically degeneration, wear and tear of the facet joints and the disc and the ligamentum flavum buckling in, all cause stenosis. The same degeneration, which is osteoarthritis, it happens in your knuckles and in your knees and your hips and every joint in your body. Everything that moves, every joint that moves gets degeneration. Well, you know how your knuckles get bigger due to the degeneration and bone spurs? Well, the facet joints get bigger in your back from the same bone spurs and arthritic process, and the chronic inflammation of the joint cause the bone spurs and the calcifications and the overgrowth. The difference is in your finger, the knuckles just get bigger and kind of look ugly. In the lumbar spine, nobody sees it, but the overgrowth of the facet joints crowds the nerves and then pushes on the nerve and causes the nerve pain. Now, how do we know it's nerve pain? Nerve pain typically comes on from standing, especially talking to somebody face to face where you're trying to stand up straight and act like a man and be somebody responsible, or woman. But standing face to face somebody standing up straight is typically when you're going to feel the stenosis the worst, because your spinal canal closes down when you're erect. And then bending forward will help. So if you bend forward slightly, you see a lot of older people slightly bend forward. Well, that relieves the stenosis. It opens up some of the room for the nerve. So standing up straight's the worst. And then typically as you start to walk, you'll feel a little better because we bend forward a little bit when we walk. But then after you've walked for a couple blocks, typically it'll catch up to you. It'll start to hurt in the back, into the butt, down the back of the leg, sometimes in the front of the leg too. But the more it goes down the leg, the more we know it's nerve pain because that's where the nerves go. So as you walk, you'll start to get it down the leg. Well, how do you relieve it? Well, you either bend forward, you stop and you bend forward, or you sit down, because when you sit down, your spine flexes and it opens up and it relieves the stenosis. So, the hardest part about our job as a spine surgeon is knowing what's causing the pain, and with how much certainty do we know what's causing the pain. And we never know 100%. There's always some guessing game there. But one of the key factors to know spinal stenosis is if you can only stand for 5 or 10 minutes and you start to get the pain into your back, into your butt, going down the back of your leg, and then you sit down and it goes away, well, there's a high chance that's from spinal stenosis pushing on a nerve. And so, and if that only happens part of the way and you've got other types of pain, that's what we have to sort out is how much of the pain is coming from the stenosis, and therefore is surgery worth doing? What are the risks of the surgery? And is there a high enough chance the surgery is going to help you that it's worth the risks and worth the recovery? Well, that's when we decide to do the surgery. So the key symptom is that standing and then walking, especially if you can only stand for 5 or 10 minutes, or you can only walk for 1 or 2 blocks. Well, that's a basic human function. Nobody wants to have spine surgery, but nobody wants to live where they can't stand and walk for 5 or 10 minutes. And the reality is that's the normal human condition. That's what happens to humans is the stenosis develops and they can't stand and walk for 5 or 10 minutes. Well, thank God we can do surgery, because surgery actually takes the pressure off the nerves and allows people to stand and walk, which again is such a basic human function that it's generally worth doing. It's worth taking on the risks of the surgery to get that kind of relief, so that instead of 5 or 10 minutes, you can stand for 30 minutes to an hour. And that changes the quality of somebody's life dramatically. Our most grateful patients are people who have spinal stenosis. We do a microscopic laminotomy, decompress the nerves. It takes us an hour to do one level typically. Do it as an outpatient. People go home. They have pain for 3 to 5 days typically. And after 2 weeks, it's like we've given them their life back. And, I wish you could capture some of that magical moment of when I see people after the surgery or when they come back to the office and they're just so grateful to have their life back. And, it's such a magical thing. So by all means, there's risk with every surgery. It's always the last resort. We always try and do everything else. We got our app, the Back Doctor app has a whole rehab program on it. I do epidurals. We got medications. You can try acupuncture, Reiki, energy, hypnosis, try anything to avoid surgery. But the bottom line is if you have pinching of a nerve, surgery is typically the only thing that really takes the pressure off the nerve and can help people. And that's what physical therapists and chiropractors and everybody else will tell you. That's when they refer us patients. They go, look, this person's got nerve pain. They've got a mass pushing on the nerve. I can only do so much. I can get them into a 6-pack. Well, their muscles are strong as a rock. Every time they stand up, they still have pressure on the nerve. And that's when surgery works. But at the same time, it's important to understand what are the limitations to the surgery. The surgery can take the pressure off the nerve. That's a no-brainer. We'll do 4 to 6 of these in a day. And it's the most common surgery we do, helps people the most. It's still the same basic surgery we do on the pro athletes. When we do a discectomy, they got a disc herniation, we still do a laminotomy. We make more room for the nerve. We go take the piece of disc out. Our results of doing the discectomies and after a laminotomy in athletes is like 89% return to pro sports after 3 to 6 months. So it's a great surgery, but why is it limited? The most important thing about having a bad back and potentially having surgery is understanding what are you dealing with? What are the limitations? What can a surgeon do? What can a surgeon not do? Well, what the surgery doesn't do, it doesn't fix a slip or a scoliosis or a real collapse of the foramen. So if you've got a mechanical problem where the spine is tilted to one side, or say you have a spondylolisthesis where one bone has slipped forward on the other bone, well, if we go in with a microscope and just make a little more room for the nerve, it doesn't fix that. It doesn't fix any structural collapse or asymmetries, obviously. One of the great things about the surgery is we're not doing a whole lot. We're just kind of sneaking in, making a little more room for the nerve, getting in, getting out. Everybody goes home, everybody's happy. But we're not fixing the fundamental structural problem, which is typically caused from the degeneration and the wear and tear. Well, there is no good cure for that. But so what we do is we make more room for the nerve and then build up your core strength, get your muscles strong to keep some stress off the spine. And hopefully that's good enough to keep you active and keep you enjoying your life. But if you have the spondylolisthesis, the slippage, you may need a fusion, screws and rods. If you have a scoliosis or the foramen, which is the hole where the exiting nerve comes out. So the microscopic laminotomy really treats the traversing nerve, which is the nerve in the canal, in the central canal. So an example is L4, L5. In between the L4 and the L5 vertebra is the L4, L5 motion segment. It consists of the disc and the facet joints. At L4, L5, the nerve coming out the foramen, the exiting nerve, is the L4 nerve. That goes into the front of your thigh. Well, if you've got foraminal stenosis, that hole is closed down. This little microscopic laminotomy typically doesn't treat that very well because in order to open up that hole, we have to remove some of the facet joint. And if we take out too much of the joint, it'll cause instability. So foraminal stenosis is typically best treated with a fusion because the fusion jacks the hole open and locks it in place. Now, that being said, we do this pretty cool tubular surgery at a 30-degree angle with the microscope, and we can take out some of the facet joint, do a foraminotomy, and take out soft disc herniations, which can really help for the foraminal stenosis. But typically, if you have collapse and degeneration of the segment and the hole is closed down due to bony degeneration, doing the laminotomy is not going to help the foraminal stenosis and the exiting nerve. And I know that's a little complicated, but it's important to understand. If you're going to think about having surgery, you got to know the difference. Is this your exiting nerve or your traversing nerve? Now, the traversing nerve at L4, L5 is the L5 nerve. The L5 nerve goes into your butt, down the back of your leg, around to the side of your calf, and to the top of your foot. So if you've got pain going in that area when you stand and walk from L4, L5, it's the traversing nerve. That's the one in the canal. That's the one the microscopic laminotomy works for. And typically 80 to 90% of the time, people's pain from stenosis is the traversing nerve in the canal. And therefore the microscopic laminotomy is the best treatment. The other thing the microscopic laminotomy does not treat is pain from arthritis, degeneration of the disc and the facet joints, which causes back pain. The little keyhole microscopic laminotomy does not treat. Why? Because we're not doing anything to it. We're just taking the pressure off the nerve. It only treats nerve pain. Therefore, how do we know it's arthritic mechanical back pain? Well, that's arthritic pain. You know how your knee or your hip can be arthritic and you wake up in the morning and it's stiff and then you walk around, you take a hot shower after 20, 30 minutes, it loosens up, it feels better? That's the same thing with the back. Mechanical arthritic back pain, stiff in the morning, loosens up, and then towards the end of the day, the more active you've been, the more it hurts again, the back pain. This microscopic surgery is not going to help that. That's mechanical arthritic pain. What surgery helps that pain? That's the fusion. Because if the disc and the facet joints are so painful every time you move they hurt, well, you have to stop the motion. We put in screws and rods and get bone to grow across the motion segment. It fuses together. It never moves again. It'll never hurt again. But the downside is that's a bigger surgery, longer recovery. And if you fuse the segment, stop the motion, it can put more stress on the disc and joints above and below and increase the wear and tear on those, and you may develop problems from those down the road. So we do fusions, but we try and avoid them because there's a price to pay. It puts more stress on the other levels. So if we can get away with a microscopic laminotomy, just take a little pressure off the nerve and then do your core strengthening to keep the stress off the spine, that's our preferred way to go if you don't have a significant slip and scoliosis and foraminal stenosis. So what I'm going to talk about with the surgery and the recovery process is just a one-level microscopic laminotomy, which is a very small incision. It's less than an inch. We do it as an outpatient typically. Most people go home the same day, several hours after the surgery. And the recovery, I'd say people feel like a horse kicked them in the back for 3 days. You feel sore. I mean, it's still surgery. And people say, are you going to use the laser on this? You're not really making an incision, are you? Look, the laser is total BS. I got a whole nother podcast on that. The laser, anybody I know who uses a laser, like basically what they do is they do a microscopic laminotomy or maybe an endoscopic laminotomy, same basic thing. And then they just say they used a laser because it sounds good. And believe me, I wish I could use a laser. They've been around for 10, 15 years. If they worked, I would use it. They have no functional purpose in spine surgery. I think that basically most surgeons, and this is my conjecture, I'm not meaning to badmouth anybody, but my conjecture is they do the same laminotomies as everybody else, and they just turn the laser on at some point to say they used a laser. and have no proven benefit whatsoever. Now, maybe they coagulate the disc a little bit, or maybe some blood vessels, or maybe they zap the fat, and get some stem cells out of the fat. But basically, no surgeon I know who's a legitimate, solid surgeon uses the laser. And maybe we will in a couple of years if we find a purpose. And my point about that is what people want is they want a permanent fix. They want the pressure off the nerve, but they want it to be non-invasive. Well, those two things don't go together. If you're going to go in and take these bone spurs and take the pressure off the nerve, you got to do some work. You got to make a hole. You got to make more room for the nerve. And if the laser, you can't burn the structure putting pressure on the nerve without risking burning the nerve. So it's a waste of time. No more talk about the laser, but you get the point. Is it's still surgery, even though it's minimally invasive. There are still risks of every surgery. There's a risk of bleeding, infection, spinal fluid leak, nerve damage, which can be numbness, weakness, pain. You can die from stroke, heart attack, and death from any anesthetic. But overall, the complications of this surgery are very rare, and usually they're treatable and manageable. So we're back to recovery. It's about 3 days of soreness in the back. I'd say most people say by the end of the first week, they're kind of over the hill, especially a single level laminotomy. Now, for every additional level we do, add about 25% to what I'm telling you. So if you're going to have 2 levels done, well then instead of 3 days, make it 4 days. And if you're going to do 3 levels, add another day. So just add 25% for every extra level to what I'm talking about. So we're going back to the 1 level. 3 days, horse kicked in the back, but manageable. You can take pain medication. You can get up and move right away. You can walk and talk and move around and be in a car. By the time I see people back 2 weeks after the surgery. Most people are not really having pain at 2 weeks. 70 to 80% of people after a single level microscopic laminotomy are not taking narcotic pain medication 2 weeks after the surgery. We tell you after the surgery, no BLTs, no bending, lifting, twisting. That just means take it easy. The neuromuscular control, is a fine, unconscious thing that happens. These muscles are firing and protecting your spine all the time. Well, when you have surgery, it throws it off. It kind of throws them into chaos, and that throws them out of whack. Well, it takes 4 to 6 weeks for that neuromuscular control to be reestablished, for your muscles to fire to protect your spine. So you don't want to start acting crazy 4 to 6 weeks after the surgery. You want to give your body time to heal. Now, most people can go back to work after a week. But I plan on 2 weeks. I tell people, look, take 2 weeks where nothing's really expected of you. You can work from home after 2 to 3 days. You can ride in a car, but plan on 2 weeks off. Let your body heal. Give it time to heal. We generally start physical therapy 4 weeks after the surgery, where then you start working on your core strength. And our app, the Back Doctor app, has the whole rehab program in the app. It's free in the app in the Google Play Store. And we've got physical therapists all over the country, but especially Southern California, from Bakersfield, Fresno, Santa Barbara, Riverside, Temecula, San Diego. We got physical therapists everywhere who know our program and can teach people the program after the surgery. And they're basic exercises. And no matter where you are in the world, a good physical therapist can teach you these exercises and how to do them, and make sure you're doing them with proper form. And our program is a 5-level program of strengthening. So based on how strong your core is, tells us what activities we allow you to go back to do. So 5 is the hardest. Well, you start at level 1. When you get to level 2, we know your back is strong enough. We let you go back and do an elliptical and swim and bike and start to walk on a treadmill on a hill. When you get to level 3, you can start doing more rotational exercises. You can run, and you can generally go back to more sport-specific exercises. So for our athletes, when they get to level 3, we'll let them go back and start throwing and skating and jumping and doing more of the sports stuff they need to do, and their sports training with their trainer for the team. And generally, return to full activity is 3 to 6 months. So in summary, the microscopic laminotomy, the symptoms are typical for spinal stenosis, where it's the standing and walking pain relieved by sitting down. The surgery is the laminotomy, making a little more room for the nerve by removing the ligamentum flavum, the facet joint that's overgrown, and taking out any disc bulging that's relevant. And it treats that traversing nerve, the central stenosis, but not the foraminal stenosis, not the slips, and not the scoliosis. So it's a small surgery. It's great because we're not doing a whole lot, but it's also limited in how much it cures. And then after the surgery, you got to get your muscles strong to keep the stress off the spine, and that's what you can do for the rest of your life to keep yourself happy. So I hope that's been helpful. If you have any questions, please visit us at watkinsspine.com, or you can email me directly at robertwatkinsmd@yahoo.com. Bye-bye.